And we're good to
Okay.
go.
All right. Welcome, everybody. I'm Judith Feinberg. I'm a ID doc at WVU, and I'm also the chair of the TREAT task force that is one of the subparts of the state's elimination plan for hepatitis C and HIV. So, with that, we'll get started. So, we've made fantastic progress in curing hepatitis C. Uh, I can remember not that long ago, maybe not even 15 years ago, this wasn't really, this was rarely possible. But despite the fact that we have amazing medicine now, um, you know, the majority of people are just not receiving treatment. So this is data from the CDC from a couple of years ago. And this is how the proportion of people who actually got a prescription and started treatment within a year of their diagnosis. And you will see it's less than a quarter for Medicaid, and probably close to 90% of the people with hepatitis C in West Virginia are Medicaid insured. A little bit better for Medicare, and even people who have private insurance, only a little over a third of them have been treated within a year of diagnosis. That's that's not very good, folks. That's not the way we should be doing things. So there are a number of obstacles. I think a significant one, and those of you who are part of ECHO are again running against this trend, but many clinicians who completed training before about a decade ago are unaware that Hep C can actually be cured, and that not only it can be cured, but be cured with minimal side effects, because the medicines we had before the current ones were just god awful. Um, and in fact, a lot of people weren't even eligible for these interferon-based regimens because interferon was so toxic. Um, and in that era, before about 2016, these clinicians, and that's probably many of you on the Zoom today, uh, were aware that the medicines we did have didn't work very well and did have a ton of side effects. And in those days, Hep C management was really in the domain of hepatologists and GI docs, not even so much ID docs, although some of us were treating um, after about 2000, but not that many. And there is and continues to be tremendous stigma about hepatitis C, largely because it is transmitted through injection drug use. And of course, that is highly stigmatized. There is ongoing tremendous confusion about how to interpret the serology for hepatitis C. I was actually on a call yesterday for a statewide project to help identify uh, women who are capable of bearing children and identifying them early enough so that they can be cured of their Hep C before they become pregnant. And it was amazing when you think about the birth score that gets filled out with at every birth of the state. It, people filling that out don't know what infected with hepatitis C means serologically. That was pretty dramatic thing to learn. And I think a lot of people just lack confidence in how to diagnose and treat something that's relatively new to them, since this wasn't something that primary care clinicians did, and a concern that it may be complex. And, there was not easy access to expert guidance. I think also a lot of people just don't know that the current federal screening guidelines are that everybody 18 and older should be screened at least once in their lifetime. And that has nothing to do with whether they have a risk for hepatitis C, because some people are not aware of their risks. They may be the rare individuals who got their Hep C heterosexually, or through blood transfusion before the early 90s. Um, And it just people are just not aware that everyone should be screened. There is, of course, a lot of discomfort talking about injection drug associated behaviors. You know, and this is also holds very true for HIV as well. You know, everything that people do behaviorally to acquire hepatitis C and HIV, you know, tends to be either something that's stigmatized or something that's not comfortable to talk about. And I think there's this is bidirectional. I think providers are concerned that patients will be embarrassed or angry if their clinician, if they interpret the request to test for hepatitis C as the clinician thinking poorly about them, that maybe they inject drugs or they may be an addict or whatever that perception is. And I think, you know, for a lot of people, there's a perceived lack of time and this kind of, it's not my job to do this. For example, we probably see more people with hepatitis C in emergency departments than almost anywhere else because injection drug use carries so many other problems with it that are emergent. And, you know, ED docs will say they're too busy or it's not what we do, or we don't want the medical legal responsibility. How are we going to follow up if these patients don't come back? And people in primary care, as you are more than well aware, you have a limited period of time to spend with each person. And so, you know, this concept that it's going to take a lot of time really gets in people's way. So here's the U.S. Preventive Services Task Force that is part of the CDC. Who knows whether we will continue to have such a task force? But now, 6 years ago, they uh, published the recommendations for universal screening. And it's every adult at least once. An adult here is 18 or older. Every pregnant woman in every pregnancy, because you could certainly acquire hep C between pregnancies. And then certainly everyone with risk factors on a regular basis. Now, what does regular basis mean? That's not so well defined, but I think if you're taking care of someone who injects drugs, then at least every 12 months and probably every 6 is a good time frame to recheck. So, of course, you probably know this by now. If you've been part of ECHO for a while, you got to order the correct test because antibody shows up pretty early, you know, within a month to 3 months after infection. And almost everyone will be antibody positive by 6 months. And we do have these rapid tests that are positive very quickly, you know, 12 to 15 minutes. But without a confirmatory nucleic acid test, this is a worthless piece of information. She can't do anything with it, right? Once somebody has met the hepatitis C virus and has developed hepatitis C antibody, that antibody will be positive for life, even if they're cured of their hep C. And so it doesn't tell you anything. Doesn't tell you whether somebody's been cured already. Doesn't tell you whether someone's been needs to be treated. And the reason for that is these confirmatory tests tell you that there's active viral replication. And the most commonly used nucleic acid test is this RNA polymerase chain reaction, PCR. There are other nucleic acid-based tests. They're really not very commonly used. There's a qualitative yes/no test, which I think also is not terribly useful. I think you really want the quantitative test, the viral load, which will tell you how much hepatitis C is in a cubic milliliter of blood. And you can detect this before antibody shows up as early as 2 to 3 weeks after infection. Now, mind you, it will show up during acute disease. And then in the minority of people who are able to clear hepatitis C on their own, uh, that's, you know, uh, that's why the surveillance definition from the CDC says that you need a viral load that's positive at least 6 months apart so that, you know, people who are going to clear the Hep C, have a 6-month period to do that. After that, you wouldn't be able to find virus in their blood. So the correct test to order, of course, is antibody with reflex to RNA PCR. And it's just, one automatic step after another. If the antibody is positive, the lab goes on to check the PCR, and the state lab can now do this. The problem with it, which so in terms of in support of like county health departments, the problem is that PCR requires overnight delivery, and that winds up being expensive. So, I don't actually know the extent to which the various county health departments in the state are availing themselves of this possibility, but the state lab in Charleston can now do a PCR. And there is this, it actually was a year ago, June of 2024, that the FDA approved this new test that is a point of care test. And within an hour, about an hour, this test can not only tell you somebody has Hep C by antibody, but they can tell you that they're RNA positive. So in a setting where a prior authorization isn't required, you could literally test somebody, have them hang around for an hour, doing other parts of their medical follow-up, and send them out with a prescription on the same day. The test and treat way of doing things. Genotype, I'm working hard on trying to convince West Virginia Medicaid that we should abandon genotype testing, and I'll get to that in a second. But before we had pan-genotypic regimens, you needed to know the genotype because not all of the combination medicines that were curative would cover all of the genotypes. And specifically 1A, is certainly not only the most common in the United States, but also the most common in West Virginia. Genotype 3 is now the one with the most rapid rate of disease progression. We used to consider genotype 1 to be that, but all of the medications on the market treat genotype 1. But about a quarter of the Hep C in our state is genotype 3, and you need to have a pan-genotypic regimen, something that treats all 6 genotypes to cover genotype 3. So since 90% of the folks with Hep C in the state are covered by Medicaid, and since Medicaid's 2 preferred regimens are both pan-genotypic, the only reason you would want to get a genotype is to possibly distinguish reinfection from treatment failure. But note, if the genotype doesn't change, that doesn't help you. And since genotype 1A is the most common genotype, if somebody does not have an SVR12, isn't cured, or turns up positive at some later point, and they're still genotype 1A, you don't really know whether they were a treatment failure or they got reinfected. So, and genotype testing is expensive. So I'm on a mission to convince Medicaid to ditch this requirement. I hope I'm successful. So that is the end of the Hep C stuff. I would just spend a minute or two to say pretty much everything I said about Hep C is applicable to HIV, right? Patients don't like to talk to you about their sex lives, and most clinicians are not very comfortable talking to people about their sex lives. And as somebody who was been doing HIV research and care for, I don't know, 4 decades, I have learned to say, without any strange look on my face or any weird inflection of my voice, say to people, would you have sex with men, women, or both? Bingo. That is just it's a one question thing, but most people are still really not comfortable doing that, and we lose a lot of opportunities to appropriately advise our patients and guide them when we really don't have accurate information about um, their social circumstances and their behaviors. And just like Hep C, HIV is one of these things that the federal uh, public health system, since September 2006, so almost 20 years ago, said we should treat, we should test on an opt-out basis every single person 13 years, not 18, 13 years old and they said up to 65, which I think is ridiculous, as people older than 65 have sex too. But they said everybody 13 to 65 who has ever had sex. Well, sooner or later, that's just about 100% of people. Um, so it really means everybody should be tested for HIV, like everybody should be tested for Hep C. And for both chronic viral infections, you do this on an opt-out basis. Opt-out means the patient can say, I don't want test A, B, or C, but you don't have to get specific permission for it. And really, when people sign their name at entry to the clinic to receive medical care, they are agreeing to whatever it is that you're going to order for them. So unless you make a big thing out of it, it's not going to be an issue. And if people do raise the question, the answer is the federal guidelines say everybody should get this test once so that, that way people don't get hung up or upset that you've somehow targeted them and have some negative feeling about what their potential social or sexual life is like. So let me stop there. And I see Jen already uh, put her picture up. So does that mean you have a question? Shoot.